So I think what I'm going to suggest is I would request all our panelists to just keep their video on. And there are some very nice comments. I think, Larissa, thank you. You responded to a couple of comments just talking about liver kidney transplantation, but also pointed out rightly that you are the only center at Birmingham who has a liver and kidney departments co-localized in the same hospital. And that obviously makes a difference because, you know, as Max was pointing out, I think primarily nephrologists need to make sure that we keep in touch, keep our patients in touch, should I say, with the liver colleagues. And there's a very lovely book for young readers affected by ARPKD called Logan's Lumpy Bumpy Kidneys, available for download from Amazon. So I certainly had a quick look at that. And there's the InfoKid website, which has been put up. So just it's starting from the top, I think I'm just going to read through some of the questions. So what is the youngest age you have requested nephrectomy due to ARPKD? Was this due to BP or growth or a combination of both? So Larissa, initial comment from you perhaps, and then I'll request Max to perhaps give a little bit of an insight from the registry.
I mean, this is always, like I said, a very difficult decision, and the youngest would probably be kind of within the first month of life, and that's usually because the patient is stuck on a ventilator and you can't get them off a ventilator. That usually is a sign of desperation, and we do tell the parents that actually this may not work, and you know, it is okay for us not to go ahead and do this. So it's not usually for blood pressure. People do it for you know, in the early period within the first month of life, for helping the breathing. Later on, they may do it for hypertension and to create space. But like Max said, and as we reviewed back in the US in 2013, when we kind of came together as a consensus group, there's no evidence for doing it. And people do it because they get stuck, and actually sometimes you just have to persevere and ride out a difficult period, and with the trust that actually it will get better, and you're not necessarily making things better, because actually if anything you're going to bring the renal failure closer by removing a kidney. So you have to always bear that in mind, and not to rush into these decisions. And we, you know, as a team in Birmingham, we always make these decisions together. And then from the combined liver kidney transplant as well, our top reason for combined is actually ARPKD, but we get referred all the really severe patients from the UK and also from Ireland. So so we do see a skewed view. But yeah, doing it at the clinics together works really well, and we do it for these conditions that are very similar to that as well, that have liver and kidney disease.
Thanks, Larissa. Max, please.
Yeah, the youngest I think we have in the registry, or even close by, was I think done in the first week of life. I agree that maybe it was done more frequently some years ago, and people are a bit more aware of the consequences, and that usually it is a situation of desperation where you think, okay, well, what can we do to help? There's maybe one more aspect that we've seen in a number of kids, and that was also seen in the US. That Lisa Gay Woodford tends to tell that if you take out one kidney, then in some of these kids, the other kidney will start to grow very rapidly. So we cannot fully explain it, but it's something to be kept in mind that if you do unilateral nephrectomy, you at least need to be aware that this may end up in a situation where after 6 weeks or so, you will also be facing a very large contralateral kidney that you may then in the end also have to take out. So that's why we at our center have become even more careful to even do unilateral, and we cannot fully, at this point we do not understand why this happens in some of the children and not in some of the other kids.
Yeah, no, that's really interesting. And, so therefore, all those initial points about, if this respiratory, watching the amount of fluid that is being given, the adequate control of blood pressure. And of course, it makes, as Nikos will tell us, dialysis quite tricky as well, because you can have problems when taking the kidney out. So next question we have is the graph showing kidney survival is interesting, with 50% survive towards 20 years. Do you think this because of the increased understanding of the disease and its management, or something inherent within the disease itself? I think, Max, this was for you, perhaps, when you talked about the genetics. Thank you.
Right. Why is this? I think that what was written in the textbooks was mainly based on the clinical findings, and the clinical findings that were most prominent to all of us were the most severe causes. And what was written when I went to med school and so on was based on the experience of very good people in the field, but there were no registries and international collaborations, etc. back then, and not the longitudinal follow-up that we can now look upon. So the perception was probably much stronger, influenced by the severely affected kids. Then again, genetics has developed over the last 20 years or so. So the gene that causes ARPKD, mainly causes ARPKD, was identified about 20 years ago. So that is also something to be kept in mind. I would say we now we perceive the broadness of the disease much more than it was previously done, and I think this is the main thing that that affects it. It would be it would be very nice if I was able to say it would be that it was the consequence of our treatment, but I'm afraid at this point I think I cannot yet.
Yeah, no, Max, I think that's a really important point. Larissa touched upon it as well. We've had perhaps a skewed version from, the most complex patients. And what we're getting now is a more balanced view of what the disease is. And as we've highlighted, so even surprised the professionals who've been looking after these patients for a long time, including our adult colleagues. Next question is from Heidi. My son was thought to have ARPKD at 3 months and was a working theory about, before diagnosis. I think Heidi's making the point that it was a difficult condition to understand. And by the time they got to a nephrologist, there was a time lag. And she's asking the question, is there training, more up-to-date knowledge of the condition for general doctors and pediatricians now, as this would be hugely beneficial? So is there something which we could, direct people to? And I've sort of put in the InfoKid website as a place, but I think you usually get to that site, I guess, by the time the diagnosis is already made. Her question's more generic about people meeting the child and family before. Any comments? So Larissa, maybe first you, and then.
Yeah. I mean, I'm also the rare disease lead for Birmingham Children's Hospital, where we actually set up a centre for the rare diseases. And we find this not just with kidneys, but with all conditions, all rare conditions. There's all, it can take, I think on average, it can take 4 years to get a diagnosis of a rare disease. That's not in kidneys, not in ARPKD, but basically it can take ages. And, you often, I think you have to have an average of 5 doctors before you actually get your diagnosis as well. So for kidneys, we're actually quite luckier than pediatrics as well. But I think the information, what I always advise pediatricians when I'm talking to them on the phone, when they've got a condition like that, is to point them towards, tell the pediatrician to have a little read before they go and talk to the family, inform themselves, have a look at the PKD Charity website, which is fantastic, and it's got really all the information you need to tell the family as a pediatrician. And also Renal Radar has actually got information now, I think, on 50 different rare renal conditions. And then the other place that you can get lots of information is Orphanet, and that's a European site. And then there's NORDS, that's NORDS, which is the American website. So I always advise, like, clinicians, when you approach a rare disease patient, inform yourself first, because otherwise you're just going to give them information that actually you're not sure about, and that just makes it worse for them. So it's a complicated thing.
Yeah, no, thanks, Larissa. I don't know, Max or Tassos, did you have any comments, because you would have dealt with a lot of rare conditions. I guess what Heidi was pointing at was almost like, with now us knowing so much about rare conditions, and although they are rare individually, collectively they are a significant group of conditions for our patients, and whether we almost in medical schools we need a separate teaching that rare conditions need to be thought about as a collective, so that broadly it is much understood. I don't know, Tassos, would you want to comment further?
Yeah, no, I think it's very difficult to keep up to date with everything that's happening, and what we previously known perhaps as a chronic liver disease or chronic renal disease, and now it has a name to it and has a genetic association, and we can prognosticate as well. I think the main thing is that there has to be awareness of that there is a problem here, and refer and speak to the relevant people as soon as possible. Because the answer may be very simple. There may be a whole network, as Larissa said, of a service established for these patients that perhaps the families are not aware of. Yeah. I think awareness days and these kind of initiatives that the PKD Charity and our charities do as well. These are a great tool to bring awareness to professionals and the families and all your stakeholders. From the renal point of view. When you do your educational days, and that's a really helpful way of passing the information on.
Thank you. Max.
Yeah, I agree. It's all about information and awareness. In Europe now, these European reference networks for rare diseases may be a helpful step in that way, because that's also about making the available data also available for the family and the patients, and also setting up some standards of care across Europe in different countries. So I think there is a growing awareness that, as you've pointed out, that jointly the rare diseases are a common thing. This may maybe take a while to go through to university, but maybe yeah, I think we are much more aware of this these days, and we'll pass it on to the students. There was one thing that I just wanted to add on the previous comment that I made on the 50% survival, that just came back to my mind. There is indeed one area in pediatrics that I think has developed tremendously over the last 20 years, and that is neonatal intensive care. And that may also may have made a difference now, that some of the kids that passed away maybe 20 years ago because of the lung situation very early in life will nowadays survive, and then, as we've seen in the initial talk by Larissa, if they make it through that first month of life, then the overall prognosis is better than previously thought, and that is something to be kept in mind. And then a last comment: for all these registry data, we also always need to be aware of potential inclusion biases, etc. So that's just a caveat to be kept in mind when looking at
No, absolutely. Data. Nikos, did you want to make a comment as well, please?
Thank you. I mean, one point that is not clear from the question is, was the hospital one that had pediatric nephrologists, in-house, let's say, or did they have to come to the once a week follow-up of cases? So that might have played a factor as well.
Sure. No, that's helpful. And so we are in the last sort of 5-10 minutes. So I think there are a few questions, 3 I can see. So first of all, a bit to do with the, how do we manage them clinically? So kidney related from Claire Floyd, with fluid being a key related issue to, which could worsen ARPKD like we were discussing. Is the transition to food, from milk, is that a challenging time? I don't know, Larissa, did you want to comment on that?
I think if the child's able to feed themselves, which a lot of children with severe ARPKD may not be able to do, and they're on tube feeds. If they are, then actually transitioning to solids does make it easier. One thing I should say is that these patients do need a lot of water. The key period where we get that low sodium is actually in the early kind of first few months of life. And then later on, it actually tends not to happen. So overall, these children do need quite a lot of fluid. So we're kind of talking about that early period. But yes, in terms of just kidney disease in general, once you're onto solids, nutrient dense foods, full of calories, then it makes it a lot easier.
Fantastic. And then how important is controlling potassium and phosphates through diet from early on? Are there any good info advice sites on meals, foods that are best for this? I think it's probably a generic question related to kidney function. And I don't know, Max, did you have any comments you would nuance for ARPKD here for the early side, or?
No, I think it's the general aspect of chronic kidney disease that is important for this. There is, to my knowledge, no really good data out there on specific aspects of phosphate or even or potassium. As we've said earlier on, for these young children with severe chronic kidney disease, having a good team that also takes care of these aspects of nutrition is really important for management.
Fantastic. I think there are a couple of comments about Susan has just pointed out there is a very good source of for living donation information in Scotland, but it's freely available on organ donation. That's on the chat, and there's a group called Medics for Rare Diseases who are working to implement rare disease teaching in medical schools. That sounds really encouraging. And there is a website address for dietary stuff as well. So I think the last question we have, well, there are 2 questions, in fact. Would a parent who was a carrier of the disease, so for ARPKD, is that the question? Would a parent who was a carrier of the disease still be suitable match? Max, do you want to comment on that?
So, according to the current guidelines, yes. So there are some reports of very mild phenotypes in persons carrying one variant of the PKHD1 gene, but at least to the current recommendations over here in Europe, it would be possible.
And Larissa, do we have any different sort of version of that, how we follow that clinically here?
Well, what we are asking there is, is something called haploinsufficiency. So basically, you've got half of the load of the normal gene, and is that enough? For ARPKD, it seems to be. However, I don't think anybody's ever looked at the data, but from parents that, you know, I've known parents that have donated to their children with ARPKD, both liver and kidney, you know, 20 years down the line, they seem okay. But I think it's a decision that needs to be taken for each family, you know, each potential donor completely separately, because they may have the same kind of, you know, kidney disease. And actually having half the gene may affect them. So say for like all ports, being a carrier for that may stop you from being a donor. But for ARPKD, no, I think we're in Birmingham, we certainly accept parents.
Thank you. Nikos, did you have any comments? As I'm sure this is something you might have had discussions around to add.
Yeah, thanks. Yeah, well, the literature says, you know, with respect to autosomal recessive mode of inheritance, you know, like ARPKD, it's okay to proceed, essentially. So yeah, I agree.
Okay. And I think there was one last question I picked up. There was one question from Tassos to Max, which I'll pose till the end. But I think there was a question from one of the parents, Karen had posed. Are there any studies on long-term impact of blood pressure medications? And I suspect this is for ARPKD. So I'm not aware of one, but Max, you probably are up to date with what's coming out from the registry, I suspect.
So there are no specific studies that I'd be aware of that would be out there. There are general studies of the importance of taking care of blood pressure in chronic kidney disease, also in children, and that would be the overruling aspect at this point. As I said, we currently have a project running where we try to look at the impact of hypertension on the causes of ARPKD, but yeah, this will take a bit more time because it's technically a challenging field to work up this data. We're surely trying to to get that issue solved.
Yeah, no, that's fantastic. So I think that are all the questions there. I think Tassos, you had a question which was a bit more technical. I think it was a specific question to Max. I might pose it just out of interest if Jane allows. I can see both Jane and Tessa here. That usually means we are in trouble. So Tassos just posed the question to you, Max. So children who were clinically being diagnosed with ARPKD, how many of them turned out to be negative for PKHD variants following genetic analysis? And second part to that question, how many of these actually turned out to have some other ciliopathy gene?
You partially answered it, but
yeah,
he did, but you know.
So we said we found 30 patients with variants in other genes that explain the disease. So pathogenic or likely pathogenic variants in other ciliopathy genes. We can solve usually about 85 to 90% of the patients by looking at PKHD1, or we find at least, I should say, we find at least one variant in something like 85 to 90%. And as I said, we now try to compare these patients to the ones with the clear confirmation. We did not find a huge difference in the course of the diseases between the patients with just one PKHD1 variant and the patients with two convincing PKHD1 variants. So we may have just missed some of the variants because of their localization. You know, this is now becoming very into the deepness of genetics, but the usual question about deep intronic variants, etc. And this is the way we try to approach this. And there was a second part to the question. Sorry, I missed that.
I think there were
No,
any.
that was-
I think you sort of answered it. I think
You've answered
Okay.
it. Yes, thank you, Max. Thank you.
Thank you.
fantastic. I think that's all from me. I'm really want to thank all the expert speakers, panelists posing all those questions. I think we managed to get through all of those questions, and we are only 4 minutes over. So I'm going to hand over to Jane and Tess, and thank you.
If I may, there is just one follow-up question from a lady. It's more to Tassos, actually, if you don't mind. She's the lady with the 5-month-old baby. She had to leave the call briefly to check on her baby. And she would just like clarification on her follow-up question about the reflux that her baby has and whether it's connected with the liver or the bile duct inflammation. So since she's just back on the webinar,
Yeah,
I wondered if you could answer that.
Yeah, the reflux has more to do with mechanical pressure as such. So it's the pressure effect. If it's a big liver, or if the baby has already got enlarged kidneys, so it's a mechanical effect. It's not so much the disease effect on the bile ducts. It's a pressure effect, and can be treated in the similar conventional way that we would treat any other reflux in an infant. Okay.
Great, thank you very much for that.
Thank you.
So that was it. Thank you. Thank you for all the questions from our attendees, and thank you very much to everyone who did attend this morning. I hope you have found it useful, informative, and as I said at the beginning and throughout, if you have any other questions that you think of, just send them to us at info@pkdcharity.org.uk, or you can get in touch through the ARPKD group. So I'd like now to thank our panelists, in particular Manish, for your fantastic chairing and management of the Q&A as well. You made it all run very smoothly indeed, and you didn't need any help from us. I'd like to thank Larissa and Max for giving us such a fantastic overview of the genetics and the clinical management of these children, and importantly for updating us and giving parents much more confidence and much more positivity than they're often led to believe from just reading the internet in particular. And Tassos, thank you for your insights into the liver and liver impairment. We know that's a very important topic to parents, and of course increasingly, as you've mentioned, to adults with ARPKD, who we are seeing quite a few of now on our groups. And Nikos, thank you for your for telling everybody about what's involved in kidney and liver transplant. Hopefully the next time we meet will be in person. Who knows? I'm back at Birmingham Children's again in Larissa's new wonderful Rare Disease Centre, which I haven't even seen yet. Great, looking forward to that.
Yes, we've got a special room for days like this, so it'll be a real pleasure. So hopefully we'll keep our fingers crossed.
Wonderful. Great. So thank you all. Thanks very much once again. And thanks to Jane and Susan for supporting today.
Before you all dash off, sorry, audience, if you're still there, you will be receiving an email very shortly, actually, asking if you can spare a few moments to complete a feedback survey. It'd be really great to get your honest views on today's event. You'll get that if you did register through Eventbrite, but we've just dropped that into the chat. So for anybody that didn't register through that channel, if you can click on that link or copy and paste it and click it and complete it afterwards, that would be absolutely fantastic. And panelists, before you don't disappear, I want to get a photograph, if you don't mind.